super pleased to have Sebastian Tello Trillo with us. He's an associate professor at the University of Virginia, most well known, I think, for his work on public economics, health economics, and more generally applied microeconometrics. Generally interested in health policy in both the US and also Latin America. And you may also know him from the podcast, The Hidden Curriculum. And I think that also is why he has such a professional setup today in his view. So we're very pleased to have you, Sebastian. Today you're going to talk about HIV, and the floor is yours for the next 1 hour. And just a note to the audience again, like Tina is going to take care of the questions. So if you have any questions, feel free to send her a private message in the chat bot or in the chat box or a group message, and then she will interfere at the appropriate times. So I hope you enjoy, and thanks again for being here, Sebastian.
Okay, yeah, thanks. And thanks for everyone for also being here. I'm gonna go ahead and share my slides. So probably takes a little bit too low, but hopefully you can see them now. Great, awesome. Yeah, thanks again for the invitation to doing this seminar. And I'm gonna present a work that is joined with Kendrick McManus, who is actually an MD uh, of specializes in HIV. So she actually treats patients with HIV, and also with Sam Mann that is at Rand University or Rand, sorry, Corporation. All right, thank you. So let me start with a little bit of definitions. So what is PrEP, which is something I'm going to talk about today. So PrEP is short for pre-exposure prophylaxis and is a term usually used to describe some sort of medication to prevent the spread of a disease. So it's actually a very general term. However, it's been very, in the colloquial sense, understood that PrEP refers to this pill that we take to prevent the contraction of HIV. So we've kind of like, even though PrEP is more like a general term for everything, we really attached it to HIV. So how does this chemical work? So it works by blocking certain enzyme, it's like a protein, right, that HIV needs to reproduce. This usually means a combination of two types of drugs, tenofovir and emtricitabine, which usually are more popularly known as Truvada and Descovy. PrEP is recommended, or at least uh, up to, I would say, 2020. Recommended for people with high risk of HIV infection. Some examples of that is men who have sex with men without a condom or being diagnosed with an STI in the past 6 months, IV users, or heterosexual men and women who have sex with high risk partners without condoms. So in some ways, this is kind of like the initially the broader recommendation of who should be using PrEP. Um, in terms of how is it administered, you should think about it as something that you take daily. So initially, you do an HIV test, and once you're negative, because you have to be negative in order to use PrEP, then you can start getting prescribed this, and you take it about every day. That that's with that asterisk. That's going to change with the current setting, but at least it used to be that case. Um, and then you do continuous checkups and follow-ups between like 4 and 6 months. At least that was in the beginning of the adherence period. So before 2012, Truvada, which is one of these medications, existed as a treatment for HIV, but it's not as a preventative treatment. So it had a different dosage and chemical combination. The and it was widely used. So in that sense, people knew about this drug and component for a while, and then been a lot of testing in thinking about using it for prevention. The other strategies that we had for prevention in HIV were obviously things like the use of condoms or harm reduction methods like safe injection sites and needle exchange programs. And so that was kind of like, I would say before 2012, the main and a lot of like obviously public health campaigns tackles of preventing the contraction of HIV as opposed to the treatment of HIV. Now, once 2012 came, so the CDC on the FDA approval, of course, of this drug HIV prevention called that we call PrEP, and it was like definitely lauded as like the potential end of HIV in the sense that like we finally have some sort of it's not necessarily a vaccine, but a type of drug that we can use to prevent people from contracting this virus, and therefore that it's going to be really useful because we never had anything as that works so well in that sense. And I guess I didn't mention this, but conditional on the patient having, a decent adherence, which is about 95% and higher. It the chances of uh, I guess not contracting work like 99%. So it's actually a pretty effective drug in some way, at least in the RCT trials that they had. Um, so I want to talk a little bit about the evolution of how PrEP has come between 2012 until now, with the only caveat that our current data that I'm going to present today ends in 2018. I believe there is data that goes broader than 2018 that we can use. However, because we're also using a combination of other data sets, not all of our data sets go up to 2025, let's say. And so everything that we have, at least consistently, ends in 2018, and we're hoping to extend it. But for now, what I'm going to present is just up to 2018. So the main thing that changed between um, 2012 and let's say 2010 is a couple of things. One, it was a very important clinical guidance that was in 2014. So the CDC finally came out with some clinical guidance on how to prescribe it and to who and what is kind of like the methodology to follow with the patient. And so that was actually very important. And then it evolved to also global recommendations about clinical practice guidelines. That obviously these have been updated over time, but they've had a the World Health Organization expanded PrEP recommendations as well. It kind of like cemented PrEP as the standard for prevention for populations that have a lot of risk. And that's kind of from 2014 to 2018. That's kind of like the main developments on that. So clinical and global recommendations on how to use this. After that, in 2019, it got an A grade, which essentially triggered ACA no cost coverage. So you can think that from 2019 and onwards, the states that had an ACA expansion, those had to, the plans from those ACA plans had to cover so PrEP essentially. Now, the caveat there, the asterisk is, uh, even though that's true, plans can still choose to do prior authorization for PrEP because PrEP is very expensive. And so there's actually a lot of difference in access of PrEP, even though your insurance covers it because of prior authorization. In 2021, we had the first long-acting injectable approved. So instead of a pill, just a long-acting injectable, which definitely helps with adherence. It administers every 2 months after initial loading series and offering adherent-friendly options instead of daily pills. So that's great. In 2025 of this year, there's a clinical guideline refresh. The CDC advised clinicians to proactively inform all sexually active adults and adolescents about PrEP, as opposed to just this kind of like narrow version. This obviously, well, I guess I shouldn't say obviously, but one of the reasons why this happened is because um, the clinical guidelines about who to suggest PrEP to were so narrow before that if you, doctor, didn't know anything about the sexual partners of your patient, then you maybe didn't know that that was a person that is you supposed to suggest PrEP to, and so they were kind of like are trying to broaden to avoid those kind of like a stigma conversations. Um, and this prescribe PrEP to anyone that asks, even without disclosed risk factors. So that's also very important. Think of places where maybe there's a lot of stigma and the patient provider relationship is a little bit not great for whatever reason. And so if the patient says, "Hey, I would like to be prescribed PrEP," that's great. We can follow the procedure for that. And so on. So that was in February of 2025. So again, not part of our data, but just want to update you guys. June 2025, FDA approval of lenacapavir, which is a twice yearly injectable PrEP that enters the market, which is great, and it's going to be really helpful for adherence. So a lot of things that are happening nowish in terms of the legal and the policy headwinds are really about um, the stability of this no cost PrEP coverage and which types of these, because now we have the long actings and the daily pills, and obviously there's a lot of uncertainty about the protections of coverage for those and how easy it is to be getting any of these for the broader population. So I think that's just important to highlight that of the current state that at least it's been happening in the United States. But for the intended purposes of our history of PrEP, we're gonna kind of like stop at 2018, and all of this stuff hasn't happened yet in our data. Uh, oh, I wanted to put this. I saw this like I guess it's not a tweet, but you know what I'm saying. A tweet the other day about how access is uncertain for this new injectable PrEP under the ACA. Okay, so what is our research questions? Our research questions is going to be pretty straightforward. Is how does the introduction of PrEP affect HIV diagnosis and HIV related mortality? And in some ways, this you may think this is like a little bit of a dark question in like, well, if you're going to provide a vaccine, if you're going to provide some sort of preventable um, help to not contract this disease. Of course, it's going to work. We've done RCTs where this works. And I think the analogy is we're not testing whether acetaminophen or Tylenol reduces your headaches. We know that that's being tried and tested. We want to see its effectiveness in the real world across the population. And the reasons why that may not happen is because there's a lot of different barriers of adoptions, right? And so we have things like financial barriers, access variables, behavioral response, kind of like a slow adoption, and so on. So there's a lot of barriers that could happen. And one of the things that we want to address in this paper that it's been one of the reasons why it's taken us a little bit, but I think finally we are making some progress on this, is we wanted not only to answer the question of what is the effect of PrEP and HIV diagnosis, like how much has it decreased, but can we have a sense of which of these barriers seem to be a little bit more salient versus the other ones? And the idea comes a little bit from my point of view, from like a policy perspective of like, if we want to make some effort, where are, and we have limited resources, where should we do that? Should we focus on the financial barrier? Should we focus on the, behavioral response, et cetera? And I think that's a little bit of where my inclination of how to frame that question comes from. So financial barriers, again, this has changed over time, and you should think that all the new uh, ways of having PrEP, the injectable ones, are definitely even more expensive than the daily pills. So just have that in mind. But Truvada's list price is between $650 to $2,000 for a 30-day supply. Copay, there's definitely copays, coupons that are offered by the drug manufacturers to offset the cost. And this varies a lot by region and by type of insurance and so on. Even if they're covered by your plan, as I mentioned, there might be other barriers like prior authorization. With a very similar theme, we did some descriptive work on this. And what we find is that for ACA insurance plans in the South, about 37% of those plans require prior authorization for PrEP, whereas for places in the Northeast, it's about 2%. So that's very like drastic differences and regionalities in like that access to PrEP. Obviously, there's access barriers in terms of like lab testing. So if I need to go get tested for HIV and there's not a lab nearby, that in rural areas, obviously that could create a problem. So any kind of like healthcare access is access that affects the initiation of PrEP and the continuation of PrEP. If you, for example, wanted to see an HIV specialist and maybe there's not one in your area, all of that, it's gonna involve a part of the barrier. And then we have some behavioral responses like the stigma about PrEP, which is really stigma about HIV. This has happened since day one of this pandemic or epidemic, and it continues on. And so there's obviously there's many ways in this factors into the adoption of PrEP. Okay, so the empirical problem that we have here is that this policy happened for the whole country, quote unquote, in 2012. I'm also talking just about United States here. So we have no state by state variation. So what we're going to do is a dose response strategy. This probably is known as a continuous if and diff now, in which we are going to use a proxy for pent up demand, which is the male to male HIV rate for each county, and use it as a dose response before and after 2012. And so we'll show you empirically if that strategy makes sense and the reasons why we think it can work. I'll stop there before I go into the review for any clarifications on the what are we doing and or anything like that. But maybe we're good to go.
Nobody has asked
Great.
a question yet, so I think you're fine. Continue.
Okay.
Thank you.
Awesome. Thank you. Okay, so live review. This is a little bit of a chunky section, but I'm gonna go over a little bit quicker than usual. So broadly speaking, there's been a lot of work on HIV and PrEP, or HIV specifically, and as a subset of that on PrEP. Most of that literature obviously comes from the public health and medical literature. So we are a lot of part of the progress that we're doing is because that literature has been done and understood and created a lot of questions for us. In economics, there's essentially less attention done to PrEP, but it's definitely growing. For the purposes of our research question, I will touch on the individual and effectiveness of PrEP versus the population level and effectiveness, and then barriers of PrEP of adoption and adherence. So in terms of the individual effectiveness of PrEP, this definitely comes from the medical literature, have been a lot of clinical trial efficacy, a lot of different kinds of RCTs. The gist of it is PrEP works extremely well when taken as prescribed. So daily oral Truvada reduced HIV acquisition between 44 to 75% in the early RCTs with higher protection and adherence. What's good. And this now, with the newer literature on this, it goes up to about 99%. And so in that sense, individual effectiveness, we know it works. There's no kind of like issues there. In terms of population level effectiveness, so we have a little bit less on this, but we have some progress. 2024 systematic review adherence interventions for oral PrEP found that clinical trials are consistently upwards of 99% efficacious. This is what we just talked about, but real world effectiveness varies. Sam Anderson, my co-author here, studied a strategy in which he's looking at the adoption of PrEP across country. So it's somewhat of a similar strategy, but at the country level. It's a panel data for 40 European countries with a staggered adoption of the WHO PrEP recommendations. And essentially, he finds that the PrEP introduction is associated with a 15 to 20% decline in new HIV diagnosis. So that's kind of like one of those estimates that we have there. In Scotland, there is a publicly funded PrEP program, and I believe they found even a larger decline, about 35% in reductions in accidents. So we have some of those estimates. Obviously, they're not going to be 99%. We've talked about there's a number of barriers. There are many papers so in terms of like the barriers and studying that, so there's actually a lot of papers, especially in the public health literature, that do lab experiments to understand and interview. So there's a lot of qualitative research to think about what are the barriers for adoption of PrEP. And the things that come up are obviously things like perception and stigma, access. So like a lot of barriers at different points of the healthcare access, from like I can't even get a doctor to it's really expensive, I don't have insurance, to prior authorization like we talked about. So cost, financial barriers. There's also disparities across healthcare access. And in some ways, like I don't trying to minimize a lot of this literature, but when you're reading a lot of this literature, really what you take away is that, wow, there's so many different ways in which PrEP is being blocked, or there's many places where we can make progress. And I think part of the research question came out of reading a lot of this and then kind of trying to answer the questions like, okay, but like, if everything matters, that's a little bit hard. Like, how can we make some progress? And how can we decide, again, if I have $100 and I have a county, where should that county spend that money? And this is a little bit of where we wanted to make some progress answering that question, which, again, I think we're going to do it in an okay fashion, and given the data that we have, but at least there's some progress there. So the data that we're using is public data. Well, it was public and then it was taken out. Now it's back in, but caveats with all of that. Fortunately, this is data before we grabbed it before they was taken out. So this is from CDC on the number of diagnoses in each county that we have, and we can get them also from some other STIs. So the CDC Atlas gives the HIV rate and the diagnosis. The HVU's data gives us the PrEP uptake. And then we combine it with other complementary data sets from the census, BLS, SEER data for county level controls. We have some regional level controls as well. A little quirks on the data is that in terms of like the number for the rate and the diagnosis, if the number is between 1 and 10, those are missing values. If it's 0, we have it, and if it's like 11 and above, we have it. So just know that that's a caveat. We played around with entering zeros for these or midpoints, and for our intents and purposes, it doesn't affect things too much, so we're not too worried about this quirk in the data. Okay, so the empirical strategy, as I kind of talked about before, is this those responses strategy. So I'm going to show you the results on logs of new HIV diagnosis at a county level. So this is just a way of evaluating incidence of how many new diagnoses HIV is not creating, so it's reducing, right? I'm going to tell you 100%. And then we're going to have the HIV rate. Actually, this needs to be corrected because we're using the county's male-to-male HIV rate that is an average before 2012. So we're using the average between 2008 and 2011. We played with average medians with just using 2010 and 2011 years. Things don't make much difference, but we're picking that baseline to be the kind of like pre-reform HIV rate, and that's going to be interacted with post-2012. And obviously, we're going to have county fixed effects, year fixed effects, and because this is evaluated within the county, we can include state-by-year fixed effects. And actually, that's going to be really nice because it's going to absorb a lot of those potential policies that are happening at the state-by-year that we think usually like things like Medicaid expansions and so on. So what are identification assumptions for this? Is counties with high HIV rate, quote unquote, would have evolved similarly than places with low HIV rate in the absence of the introduction of PrEP. And then we are also going to have this additional assumptions that counties would have to react linearly to the HIV rate. Now, this may seem like a strong assumption, but we are working on. So let me preface this, but like I think before Callaway, Goodman, and Bacon Santana 2021 paper, which actually was just got updated, so that should be 2025. Our understanding of continuous DD was very similar to DD, but now we know that in order to interpret that coefficient in a similar way, we have to add more assumptions to that estimator, which is kind of like what I'm doing in this paper. They recently, very recently, released a new estimator that helps you kind of like as you're changing assumptions, tells you how that estimator is changing. We have not done that yet, but obviously that's in the checklist. This is just because things are happening as we're evolving in this literature. Other specifications will add urban by urban code. So like urbanicity, you can think about it by year fixed effects just to capture trends on, we're comparing small places to big places. And other county level characteristics like poverty rate, median household incomes, etc. So we're going to have a fully saturated model as well if you wanted to see that. But fortunately, as a preview, this doesn't change things too much. Let me tell you some researchers' decisions on sample selection, which I think are going to be important. The baseline specification will use the following sample restrictions. First, we need to have data on PrEP uptake, but not be missing. And this is because we want to use counties in which we have the first stage. We want to have all variables not missing between 2008 and 2018, so that is known as a balanced set of counties. And we're also going to use only non-metro counties in the baseline specifications. I'm actually going to be able to relax 1, 2, and 3 and show you how our results change with that. And there is a little bit of a change. But in terms of the baseline, we're essentially grabbing 2008, 2018, all counties that have full set of balanced information there, and for non-metro counties. I'll show you why the non-metro counties. Yeah.
Chris has a question. Chris, do you want to ask the question?
Sure. I'm wondering, why do you have your dependent variable be the log of the number of new instances rather than the rate?
Yeah, that's right. We can we have also done the rate. It's mostly because as we're going to evolve into other outcomes, I just thought it was nice to standardize it in this log and interpret everything in percent. So it's a little bit of a choice related to that, as opposed to just a number.
And maybe I missed it since I'm actually talking right now. So how did you handle like zeros? Are you doing Poisson or how are you doing
Yeah,
this?
that's a good question. No, I haven't mentioned this. So we tried a number of things. The thing that I'm going to show you is actually the most simplistic. We added +1 to everything and then log it so we don't miss zeros. But we've done Poisson, we've done hyperbolic sign or inverse hyperbolic sign, and we've done different ways to account for the zeros and also, anyways, all those potential measurement errors that may come with that. It turns out it doesn't make as much difference than we thought it was. So we're keeping it. We're going to show you something that is probably one of the most simplistic way, which is to all these counties, we're going to add +1 and we're going to log it so that we don't miss the zeros.
Hans actually also has a question.
Yeah, I was wondering, Sebastian, given that you mentioned this sort of linearity assumption, I was just wondering whether you also sort of stratified the different states or counties or so into high and low, for example, to avoid this strong linearity assumption.
Yeah, that's right. So here we're using kind of like the continuous, and we could stratify it. So we actually play with that. I don't, uh, I don't think we learn anything, as particularly important. We Relative to, I don't know what I'm going to show you right now. I think the nonlinearity is definitely a strong assumption in the tail ends of things. I don't. So maybe what I should say is like, I don't think this linearity assumption is going to be exactly true for us for the full distribution. I think there's going to be definitely some spots in the high end and the low end that are not going to look linear, and so we need to definitely take that into account and be a little more flexible with that, which is haven't at this point with this paper.
All right.
Yeah, totally. Okay. So let me show you some results. So let me show you the first stage, which is PrEP uptake. Do we see PrEP being uptake over time? And the answer is yes. So who is taking up PrEP is usually people of ages 25 to 34, and the second group being 35 to 44, and then kind of like the younger or older groups do have a little bit of uptake, but definitely less growth. This is mostly up to my data, a male story really when it comes to the uptake on PrEP use. And so just know that that's part of the context in the result. These two plots that I'm giving you is using data from HVU, which is trying to calculate essentially the number of like PrEP users for a given population. It's an estimate, so it's not exactly the actual numbers. So one of the things that we wanted to see to validate this data is to do a Google rate search for PrEP or any kind of like PrEP plus HIV related terms. And we also see this kind of like increase that is happening very similar to these other ones. So we think what we're seeing here is potentially something that is real as opposed to some sort of like created by the data. All right, and then the next thing I can do is I can show you an event study, right, of exactly our study, which is our counties that have higher HIV rates taking up PrEP higher than those counties with lows, and the answer is going to be yes. So this is great. Our strategy is working in the way we want it to. And here, if you want to see like the coefficient with the confidence intervals, we can show it to you. So in that sense, the strategy seems to be working in terms of like what we think it should be working, which is higher PrEP uptake. Okay, so now to that dose HIV rate. In order to explain that a little bit, so obviously we don't have information for all the counties. So we have the HIV rate across a number of counties that we have data for, and we're getting input the actual HIV rate as opposed to categorize it in terms of higher, lower, and quantiles. And just to show you how the Y has evolved, this is I think for the full sample, the evolution in new HIV diagnosis per 100K over time. And so you can kind of notice that it has been decreasing over time, which is great. There's been a lot of strategies. You can see this in a person that is maybe skeptical could be like, wow, PrEP really didn't do anything because it's just continuing the trend that it had before. Maybe others could be like, no, look, there's this big drop here and continues to drop. So obviously just using a little bit of like mean trends specification may not give us the answer that we are looking for. And then I want to show you this, the Y, so the new HIV diagnosis by quartiles of HIV rate. So this is that discretization that we were talking about. This is all descriptive. And what you're going to notice is that, well, first, the places that have the highest HIV rate, you can definitely see that decrease, right? And these places, less so. Now, if I take this probably line out, you may start seeing some of the decreases around here. It's just because of the scale. But the other thing I want to point out here, I don't know if I can can I do a pen? Let's see if you guys can see that. Yeah, so the other thing I want to notice is that if I'm talking about like parallel trends, right? This group right here seems to be in a very different parallel trends than these three groups right here. And that actually is going to pan out in the data as well. So let me erase all of this and show you if I were to include an event study with all of these, how would that look? And it would look like that. And that's not surprising because we see that differential trend that is happening even in the scripted data. And why is that? Well, the reason is because these places here are really driven by the big cities in some way, the Chicago's, the San Francisco's, the New York, where there is a lot of attention and a lot of population of that had, counties with high HIV rates and also like high adoption of PrEP. And that's why we kind of see here a very much a differential trend, which is something that we wouldn't like per se. So this is kind of like one of the reasons why we are gonna only subsample to non very big metro areas, and I'll show you the extension in a second. But really, our data is going to come from these lines right here. So the story that we're going to be telling, at least today, is not going to be a story about the San Francisco, Chicago's, New York's, DC's of the world's per se. It's going to be about the smaller cities like Richmond, Virginia, and even smaller like counties in more rural areas, I would say. So it's kind of like more, I don't know, I don't want to say middle of America because geographically that doesn't make a lot of sense, but about a smaller city in a smaller urban areas. This is showing you the same thing, but by urban categories, just to show you. This is urban categories are categories made by the USDA about urbanicity of places and of counties, and this is just to show you the same thing that this differential trend is really be driven by the big cities as opposed to kind of like everything else, and so we are using that everything else. All right, to show you a little bit how that changes. So we have about 3,000 counties in the US. We only have information with HIV for 1,200 of those, so we can't speak to all counties. Of course, I mean, now some counties don't really have a lot of population. And then we're going to have our unbalanced and unbalanced set of counties. In terms of the statistics, ours relative to this set of counties, well, first I should point out the population. They're going to be a little bit higher than including all counties, right? But smaller than all the counties with all the HIV information because we're taking out the cities. Median income is between like 5K of each other, similar poverty rate, similar employment rate, and other similar characteristics. So at the end, the type of sample that we're playing with seems to be representative of at least this sample right here, which is all counties with HIV and information. But obviously there's some difference in the population, of course. Okay. All right. So let me show you some results. I'm gonna I guess skip the formality of showing you tables and go straight to the event studies and show you the DD coefficient because I think that's the thing to see for event studies. But I can also show you the tables if you wanted to. So this is one of the main results, which is talking about the effect of PrEP on log HIV incidence. The coefficients right here with the confidence interval right there. So what we're seeing here is, fortunately, with now our sample restrictions, we see that parallel trends that before we didn't have. And obviously, we're seeing a decrease in HIV incidence, which is great. That means PrEP is actually decreasing HIV incidence. In order to understand the size of this coefficient, we'll need to multiply each coefficient by a median county or the county HIV rate. We're going to do this by using the median county HIV rate. And when doing that, we find that for the median county, we see an average decrease of about 5% in HIV incidence. Obviously, that's for the median county in terms of interpretation. I can show you a distribution of that where this 5% is kind of like that median interpretation, but there is some counties that had a smaller percentage effect and some other counties that had higher percentage effect. I mean, with a couple of outliers with 30-40%, right? But again, the median is around that 5% decrease in HIV rates. So that's kind of like that. First, a little bit of a headline result. This graph kind of also shows you the timing composition of this, that this decrease is happening also as PrEP was having a higher and higher uptake. And so that's important for us in terms of understanding the causality of that. Now, let me show you, as I promised, some robustness of these effects. So first, this is an event study where I'm changing the specifications. So I'm doing the baseline is state by year, which is the black line. Then I'm going to add controls. I can put region by year fixed effects, which these are the urbanicity by year fixed effects to make sure we're comparing similar populations, and then the fully saturated model. And kind of like no matter what you pick is, we're giving a very similar estimate and a very similar types of event study for all of this. So we think this is robust to all those different specifications. And again, these are controlling for a bunch of different stories that we can think about in terms of identification. The other one that I like to show is this one. So one thing we can do is we can take out all the fixed effects of our regression and make it like a simple mean comparison. In comparing certain outcomes characteristics about the counties to see if they're changing, to see if the HIV dose rate is correlated with some of these outcomes. And we see that that's the case, right? When we take out all those fixed effects, what we're seeing here, I should explain. All of these are different characteristics of the counties. And they have been all normalized or standardized, I should say, to have mean 0 and standard deviation 1. So these are all normalized, and so we can make an actual comparison of standard differences. What this is really saying is that counties that had higher HIV rate had a higher percentage for African Americans that tended to be poorer and have higher population. So that's kind of like what we know from that baseline data, okay? That these counties are not very similar to each other. However, once we applied our fixed effects, we noticed that all of those standard differences kind of like go to 0. And which essentially is kind of like netting out a lot of these characteristics that are not that different and making a more cleaner comparison. What this is also telling you is that these are all as outcomes, right? So the PrEP did not affect the percent of African American in the county, the percent of population, or unemployment rate, or anything like that. So there wasn't anything that was conjoined with PrEP, right, that it was affecting any of these kinds of outcomes, which makes us a little more confident that what we're picking up is PrEP, as opposed to any of these other stories that could have happened, like, for example, better economic conditions and so on. Okay. Robustness to sample selection. So this one is important. The black one is our baseline sample. If I do a no size restriction, so if I say, let's include all counties, we have kind of the green line. And if we do all counties, so this is all counties with, actually, these two are looking very similar, and I'm wondering if they have very similar restrictions now that I'm looking at the thing. So I need to actually amend that. But let me show you. So this is about all counties versus not all counties. And then let me show you about balance and non-balance. So this is I'm only using counties that I have the full set of information, but I can also take that restriction out and maybe have some counties with maybe some of the missing values and see what drops here and there. And not surprisingly, these are very similar to each other because the regression is going to try to pull all of them together. And so point here is that there's robustness to that sample selection. So we feel like we're robust to alternative specifications. Other non-outcomes are not changing. I haven't shown you, but specification of the Y variables also doesn't really change things too much, and sensitivity to samples restrictions. So I want to do a little bit of interpretation before we go to potential mechanisms of size. So using the rates model, this is using rates and not the log. And for example, our model can explain about 19% of the decrease in HIV incidence for the years 2012 to 2018 for the median county. So the median county can explain about like the 90%, and our average is about 25% if we do that exercise. and so on. So that's a little bit if we wanted to understand, okay, given your model, how much can you explain of that full decrease that we see on HIV incidence over time? And we think that that's about 20 to 25%, depending if you want to use the median or average in some ways. So again, that it's a little bit hard. I think I have two reactions to this. My MD co-author was like, "Wow, that's very small," right? They thought that was not very big. They thought PrEP would have actually explained more of the whole decrease in HIV incidence. And I think some other reactions from an economist point of view, we're like, "Oh, okay, that's maybe big or reasonable, etc." So I think it depends on what are your priors on what PrEP would have done post 2012 that you may think this is like small or big. Okay, got some couple more minutes. So let me now show you this type of analysis, which is asking the question, okay, so PrEP has decreased about 20%. So I titled this like, why hasn't PrEP made a larger decrease? I think I can market it differently, but this is really about trying to understand which of the stories that we are hearing have a little bit more or less bite in terms of like PrEP uptake. And that's kind of the experiment we want to do here. So things are like insurance availability, right? Oh, it's all about people having or not having insurance. This is why Medicaid expansion had an effect. So this is not just about drug access, but like having access to follow-ups and broader healthcare. There's also healthcare availability. So like kind of like location, like, well, it's about like some people don't have access to MDs, different from the cost point of view. And then also the hypothesis about a stigma die. Oh, these are places where the stigma may influence in many ways between patient-provider relationships, right? Think of a rural county in Alabama. There's an inner sample, like maybe that patient is because of stigmas and prejudice may not raise things up to their doctors. Structures put in place, trust in the system, or afraid of coming out, right? Many ways that stigma could come into this. So this part took us a little bit because in order for us to do this, what RFL data set at county level, what we had to get is county level information for all of these types of hypotheses that we may have. So measures of insurance availability, healthcare availability, and stigma. So the first two were, I think, doable. So insurance availability, we have the small health insurance estimates that we can use for our sample. And that just gives us the percent of people who are uninsured or uninsured. It doesn't really tell us about like private versus non-private. So that's something that we can look into. Healthcare availability. So we have obviously information about which are the low shortage areas and high shortage areas, et cetera. That has been discretized and it's not available for every single year. So what we're reducing here is just kind of like rates of MD for a given county and using that as a comparison. And then the stigma was a little bit trickier in terms of how to measure stigma for a given county and have that in a panel format. So what we've done there is we've created an index of stigma that captures essentially whether we think this county has a lot more anti-LGBTQ sentiment versus not. And that, I'm not going to because going too much into the details of that, but in the paper, we'll talk more about that. That is constructed from a couple of estimates. So one is the rate or number of evangelical churches in a given county. Two, based on survey questions that we can get some kind of information on whether they believe in gay marriage or some other LGBTQ rights. Also a proxy for a Republican vote or an index of conservatism. So we have a lot of these 5 things in different ways and measures, and we play with different ways of combining them. But at the end, the standardization and the index seems to working well, and we're going to call out of the stigma. We use these mainly because we went ahead and read stuff on like how do people conceptualize stigma on labs and in broader settings, and these are the things that were mostly correlated for the people who are measuring a stigma with. And instead of picking one of the measures, we decided to kind of like aggregate them into this anti-LGBTQ sentiment. So obviously, you can think there's a lot of measurement error on that, but I think this hopefully at the county level, in a panel way, is a way we're trying to make progress. I think I saw a question.
Sebastian, Davide has a question. Davide, you want to ask your question?
Yeah, hi. Hi. I was wondering whether there is a role for the Peltzman effect, whereby people might risk compensate since PrEP makes, in a sense, sex less risky.
Yeah, I think so. That's obviously a possibility that could happen, and I think people think this of in the econ way, right, as moral hazard, where the way you would see that is you would see maybe increases in other types of STIs because they don't have that like protection. So I believe Scott Delhomer and Nir Alamay have a paper on the effects of PrEP on STIs, and I believe now I'm forgetting, but I believe they find increases in some of them. So I think that could be true. I don't know if the paper where the paper is currently, but I believe that's true. Yeah. Hassan?
And Hassan also has a question. Hassan.
Thank you, Sebastian. My thought about the moral hazard story is that it doesn't have to not affect HIV. So I'm thinking about moral hazard as it affects sort of cultures of people. So if there's this decrease in PrEP users having risky sex, that might have effects on non-PrEP users as well. And if that creates like a culture of risky sex, I don't think it's clear that
Yeah, I agree.
that's not going on.
Yeah, that's right. And that's something, to be fair, that we study here. So I think if the question is there a role for this to exist, absolutely. A lot of what I'm showing you is net of all of that, right? In terms of like HIV per se. I'm not obviously showing you other STIs. Okay, so what we're going to do here is we're going to essentially create a measure for all of these and do interaction, what's really like a triple interaction with all of these. And so in terms of like event study, what you see here is you see, for example, this is our baseline estimate for PrEP adoption. And this is how much it decreases once you're controlling for insurance. And we can kind of like the area under the curve is where we're thinking is going to tell us a little bit about like how much insurance is mediating, quote unquote, this effect. We can do this for stigma and a bunch of these other ones. So I'm not going to show you a bunch of these studies. I'm going to tell you some concrete numbers so you can have some takeaway. We have other ones to be done, like right one programs, funding per counties per years, and so on. So there's a number of these things that we want to play. So I'm going to show you for a couple of things, and let me give you some concrete numbers in a second. So the way we ask this question is, how much of the effect of PrEP on new HIV diagnosis changes from going from a negative 1 standard deviation to a positive 1 standard deviation in the mediator, say, insurance rate? So how much is the effect of PrEP changes when we change this by 2 standard deviations? And so a conclusion that we may come out is saying something like a 1 standard deviation below the mean insurance coverage to 1 standard deviation above a strengthened PrEP decline on HIV incidence from -2 to -4, a difference of 2.2 percentage points. So that 2.2 percentage point, 2.12 percentage points is really the difference that insurance is creating in the effect of PrEP on HIV incidence. So that's the number that we're going to try to get for a number of these things and compare them to kind of see which of these mediators maybe has a little bit of a bigger bite. Okay. So let me show you that. So on the y-axis is that change in percent or percentage points, I should say, on the effect of PrEP and HIV incidence by a given mediator. So for MD availability, which is that kind of like healthcare availability proxy, this is saying that going from a change in 2 standard deviations of MD availability in Median County increases the effect of PrEP by 0.62 percentage points. Insurance, way bigger bite than healthcare availability, so that cost barrier. Insurance increases the effect of PrEP by 3 times what it was of MD availability, so that seems to be obviously a big ticket item. We did things for unemployment, right, as a way of measuring some sort of economic condition in terms of the supply and demand for jobs, and that seems to even have create a higher difference. That may or may not be surprising to some because unemployment is correlated with a lot of economic conditions of the county and therefore a lot of healthcare availability. This one was, I don't know if it's surprising or not for some, but it created a big stigma, had even a bigger impact in where we're finding that things like, for example, insurance or healthcare availability. So that measure that we created for the stigma essentially saying that if you reduce the stigma, right, your effects of PrEP and HIV incidence has a lot more power. And then finally, we also had a measure of course, of poverty, and we found that again in our baseline result, this created like the most different. Now, poverty, again, this may not be surprising to you because that's also correlated with a bunch of things about the system of the county, and so in some ways it could be filtering through a lot of the other stuff. So let me show you some sensitivities because of that. So this is our baseline analysis. Our top three are unemployment, stigma, and poverty. But in the fully saturated model, so that's a model in which we do this exercise, but then we control for the other stuff. So we're hoping to net out all the other mechanisms. Really, the top three that come out is insurance, poverty, and stigma, right? As kind of like the three main causes of why we think PrEP hasn't adapted or could increase much its potential as much if these things were reduced. We also did a sensitivity of this based on the sample. And again, if we do that, insurance, poverty, and employment come up with the top three. So there's a little bit of sensitivity on these. I would say that probably this one is the one that makes a lot more sense to interpret in terms of the analysis, where insurance, economic conditions, and the stigma seem to be the main drivers of, or maybe barriers, and especially stigma of the adoption of PrEP or effective PrEP and HIV incidence. We've done heterogeneity analysis by race and gender and age. Age is possible, or sorry, I think gender is possible at state level, not a county. We've also done some distinguish between ACA and ICA and counties, and a lot of the insights that we're getting from the previous analysis here, that insurance matters, and but we just want to say insurance matters. We wanted to say by how much. Other steps to take here are we want to, so as I've kind of mentioned, we talked a lot about denominator areas. We're not really talking a lot about the San Francisco, New York, Chicago, DCs of the world. And so we want to see if we can do some matching it to improve the identification of them and explore other HIV AIDS-related outcomes. We want to think about coding different other potential mediators to have them at the county level. And we finally got access to an all-payer claim database from Virginia, in which we are going to use that to complement the story to talk about things like adherence. So a lot of the stuff is at the county aggregate level. We don't have any individual level data, but with this all-payer claim, we are hoping to then see like, hey, a person that starts PrEP, what are the services they get? How long did they keep PrEP for? And a bunch of other descriptors that people keep asking us. And to be honest, we don't have it, but hopefully that will come soon. And obviously your own suggestion. Just to quickly conclude, and then I'm happy to answer more questions. We find that PrEP is available since 2012. Take-up didn't really start in 2014. That's a little bit of the script result. Reductions in new HIV diagnosis follow the same patterns. Evidence showed that introduction of PrEP did cause a reduction in HIV incidence of about 20%, or we can think they can explain about 20% of the reduction of new HIV incidence. And I haven't shown you a result on death, but it would translate to about potentially avoiding 10% of deaths on average on this at the state level, and obviously showing that stigma, insurance, and economic conditions are part of the main barriers that we're finding with the data on this on the effect of PrEP and HIV incidence. Thank you very much. 5 minutes left, so happy to do that for questions.
Thank you, Sebastian. Great talk. So please let me know if you have any questions for Sebastian. But until then, I was maybe wondering, because you were pretty clear about the context and this not being like the big city story necessarily.
Yeah.
But some of the things that you are discussing are pretty different in the US versus the rest of the world, like the insurance system and so forth.
Yeah.
Just, do you have anything to say about the external validity in terms of the institutional context, or would you think what would be different, for example, in Europe or?
Yeah, totally. I mean, speaking with less than expert knowledge on the healthcare context and HIV context in all the other countries, I think one of the things that I was surprised by this analysis is how relevant stigma kept coming out. So to the extent that things like insurance and economic conditions are different in other countries, then maybe PrEP has a little bit of higher uptake than or effective PrEP on incidence than in other countries. But stigma is something that we find in a lot of different countries in many different ways, and I think that's probably a channel that will carry a lot of that external validity. Now, how that stigma is materialized is a little bit different for each country, but I think that maybe helps us in understand that external validity concern more than maybe the insurance is structured, because obviously in some European countries, healthcare validity, insurance, and economic conditions could be much better for certain areas.
Mhm.
Hi,
Yes.
Sebastian.
Hi, Hassan.
Thank you for your presentation. I had one thought. So the outcome variable is HIV rates. That's, diagnosed HIV rates.
New
And
HIV, yeah.
yeah, that's conditional on testing. And I was thinking,
Yeah,
I don't know if
exactly
the
right.
log deals with that, but aren't places that have higher rates of HIV also might have higher rates of undiagnosed HIV? So would that kind of bias the results downwards, or would the logs deal with that?
Um, so if it's so the way you would bias it is if let's say that like counties with high HIV rates have higher undiagnosed than counties with low.
Yeah.
If PrEP changed that, then yes. But if not, that's a characteristic that is about those counties that is, maybe evolving over time, but we're netting out with the fixed effect. So it would have to be like something happened in 2012 that changed that index. Now, we can obviously make a story of how PrEP changed that. And I mean, that's probably an outcome that would be interesting to think about, and how that bias would enter if that were the case. But that would kind of have to be the way of thinking in order to do that. And then that also, well, there's two things actually now that I'm thinking about that it changed an introduction in PrEP, and it changed in the way that PrEP changed it by increasing PrEP. We also seen more of that. So to the extent that all of those things are true, then yes. Yeah.
Okay. Thank you.
And Chris Rowe, Chris, do you want to ask your question?
Sure. Yeah, I'm trying to understand the sample restriction and the
Yeah.
effects of it. So my understanding is you eliminated large counties. And usually, when people do these kinds of analyses, I'd say get rid of the small counties because they're just
Yeah,
weird.
yeah.
So what I want to know is, I mean, what percentage of the US population or of
Mm.
HIV cases are being covered by the counties that you're examining? And then how does this affect you? You gave us interpretations, that there'll be a 20% reduction or
Yeah.
whatever, but are you then just assuming that the percentages you see for your counties are going to just translate across the whole country or what?
Yeah, that's right. So everything that I'm giving you is you can think that the external validity, at least within the sample, is up to the counties or up to the uh, uh, counties that we have HIV information are not the big cities. So that's about 900 counties. So in total, we have about 3,000 counties in the US. Only 1,200 of those will have HIV information. And so in the external validity gets up to 900 of those 1,200. So I don't know what the math is there, but that's kind of like that percentage of the people that we can talk about. Aside from that, I think the cities have a very different stories of the effect of PrEP and HIV incidence, because a lot of different policies went in there that it's obviously in being told by the data as well. So I definitely don't think this has that external validity to I would say cities.
But if I can ask it, I mean, on this question of population, I mean, the big
Oh, I
counties have
see.
all the population.
Yeah,
Like
yeah, yeah, yeah,
I
that's
did
right.
at one point, I looked in like the lower 50% of
Yeah.
counties had like 5% of the total population. So I'm just wondering, and I understand you
Yeah,
got
like who are we
balanced,
talking about?
unbalanced issues, but I'm just trying to
Yeah.
understand that
Is your
aspect.
and you're thinking about kind of like for that question, the denominator being like who is specifically, how do we count in terms of like population? Who counts for this? What are you thinking here?
Yeah, I guess I'm just trying to understand. I mean, take take an extreme case where 90% of the population were in these in the large counties that you're excluding. I'm not saying it's that bad.
Yeah. That's
Saying,
right.
then you're getting, I mean, kind of the margin you're looking at
It's
is
just for those 10%.
it's
No, I
not
understand the
captured.
concern.
So I'm just trying to
Yeah, I don't.
understand how.
I should have a number for you on that. I don't have it. I mean, probably the easiest thing we can do is just population wise, just talk about the difference number. But I don't have that in top of my head. I think I thought about it more in terms of like how many counties can we cover? That's 1,200. How many counties max cover is 900. But we can do the same thing with population for sure.
I'll just also mention your log plus one can get to be a real issue for small counties. I mean, a lot of these, we have a lot
Yeah.
of really small counties, like 50
Yeah.
people in them and stuff. And
Yeah,
so
totally.
actually that could be also a bigger issue when you're doing
Totally.
small.
Okay, we're out of time. So thank you for a fantastic talk. And maybe I'll
Thank
let
you.
Hans conclude.
Yeah, well, just to say that this was the last seminar before the Christmas break. We'll pick up again in February with Angelika Meinhofer, and then we have Michael Darden up in March. So stay tuned for the rest of the schedule, and have a nice Christmas all. Thanks,
Thank you.
Sebastian.
Thank you.
Take care.
Take care.
Thank you. Bye-bye.
All right, thank
Bye.
you.
Ciao.